Good morning. I hope everybody is well today. We are in for an interesting discussion. On reviewing the registration list, I know I have met a number of you, but not everyone. So as always, I am Matthew Hart, CEO for Longwoods and producers of these talks. One of my favorites and a seasoned veteran will be joining us today. Matt will happily tell you that he was the first speaker at breakfast, and he will also tell you that he thought that these were going to be an absolute failure. But years later, here we are, and Matt is maybe speaking for, I didn't check, the third or fourth time now, maybe more. We're also joined by Dirk, who will be making his first appearance and hopefully not his last. Before we get started, I would like to acknowledge that these events do have support, and supporting today's event, we have Healthcare Excellence Canada with Kim Kinder is here today, Jim Shave from Cerner, Catherine Galton from HEROC, Neil Fraser from Medtronic, Britta Kupra from Philips, Francois Dorlet from Roche, Ankit Dio from Workday. Lastly, if you do have questions, Matt and Dirk will be taking an opportunity to address those questions. You need to put them into the Q&A, which is down at the bottom of your screen. And that is it for me. So enjoy the discussion. Matt, Dirk, it's all yours.
Thank you very much, and good morning, everybody. Thanks so much for attending today. And 2 years ago, I never would have thought, first and foremost, that I would ever be sitting beside Matthew Anderson, the CEO and President of Ontario Health. It's an honor and a pleasure to. All joking aside, it's a great benefit of the tragic 2 years that we've been involved with. And secondarily, no way that I thought we would be so easily gathering so many people together across Ontario and nationally. And what you can't see, you can see that I'm sitting in a hotel room potentially, but you can't see that I'm in Sault Ste. Marie. And to be able to do this talk virtually with everybody, I think is just fantastic, and speaks to one of the changes that we've made that we'll likely maintain. Now, I'm in Sault Ste. Marie because I'm meeting with elders, First Nation elders, to help to inform collaborative transformation of the Office of the Chief Coroner approach to the review of child and youth deaths. And while I've stepped away from the meeting with the elders, I've not stepped away from the topic that we're going to discuss today. The impact over the past 2 days, or the day and a half meeting that I've had with them, and I have another afternoon today of substance use, is so far and wide and so far reaching, and clearly is so impactful in our discussion around children and youth. Parents, youth, children, families, communities all suffer, leading to the loss of families, employment, happiness, and most tragically, life. While I spent yesterday, I want to take a moment to reflect on where I spent yesterday. I was in Garden River First Nation, and it was a real honor to be welcomed into their nation. And we were in a longhouse. So we went back to the earth. There was a drum ceremony, and it really causes me and helps me to reflect on the long time frame that our Indigenous people have lived in Canada, and acknowledge their commitment, their contribution, and frankly, their leadership over the years. So I will be going back to meet with them further, and again, thanks for attending today. When we think about substance-related harm, it's so widespread, and I suspect there's nobody on this call that hasn't been touched or affected. And I know there's many who provide frontline or direct service to those who are suffering from the harm. In the past, I used to resist the word crisis, as in my view, opioid-related harm has been an ongoing and significant public health issue for many years. But what we have now is an escalating overdose crisis that is so significant that it's impacting our life expectancy in Canada and the life expectancy estimates in the US of A. Now, important, looking at the title, you'll see a public health emergency. Recognize that neither Matt or I are public health experts, and we're not proposing a solution. We're proposing, or we want to share some of our observations, and we want to talk about the seriousness of this issue. Many of you know that, but we wanted to talk about some of the recent numbers that occurred during the pandemic, and then our observations of how the Ontario healthcare system came together to tackle a serious public health problem. And you know that is COVID. And to allow you and those who are leading health systems to determine how everyone can pull together and apply the experience to reduce the tragedy and loss associated with substance use. We as a province, specifically in the healthcare system, came together in responding to COVID-19. We did things that were previously believed to be unattainable, definitely not in the time frame that was brought forward. And Matt's going to explore some of those things and illustrate some of the work that was done. So if we're going to move on to slide 2, I think it just is so important for all of us. Again, I'm reiterating, but I think so important to recognize the magnitude of opioid, how immense opioid-related harm is. Mortality is significant, but we can't forget the morbidity as well. Like, the number of deaths is tragic, but the number of people that are suffering illness and other impacts is even greater. And that brings me back to the conversations that I had yesterday and the night before with the elders, where many times the topic of the child and youth challenges and the child and youth deaths circled back to, unfortunately, substance-related harm. And so I want to acknowledge all of the families. We talk about data, we talk about numbers, we talk about all of this, but that's an individual. Each person is an individual who died, and each person brings their voice together to this conversation in the numbers to be able to hopefully speak more loudly, bring the message more poignantly, and really help us to all think about how important this is. And anyone who's on the call who have lost friends, families, patients, clients that are feeling sadness, so we all should. We should all share in that sadness. We should all share in the recognition of the tragedy, and we need to learn and do what we can. We've heard from those who are in the front line, those who are providing services, those who are receiving services, those who are suffering, that in fact, why can't we do what happened with the pandemic? Why can't we mobilize and make a response for this serious and significant problem? We move on to the next slide, Emily, please. So just a quick overview. I've talked about it. I'm going to discuss the numbers of deaths that occurred during the pandemic. And then Matt's going to highlight what was done so quickly with such cooperation and collaboration, and frankly, remained nimbly responsive to new information. And finally, provide some ideas to help you to consider how the lessons could be applied in responding to the opioid mortality data. So we go into the next slide and the next slide. So there are 2 reports that I hope have been sent out that were prepared together with the Ontario Drug Policy Research Network, ODPRN, with Tara Gomes being the lead, Public Health Ontario with Pam Lease being the lead, and our office with Reagan Murray, an epidemiologist working within our office, being the lead. And that took a look at the data of relating to opioid mortality in the period of March 2020 to December 2020 and compared that to the year prior. And what we saw was a 76% increase. The number of deaths in that period of time from March to December in the year prior was 1,162. And in the year during the pandemic was 2,050. It's a huge number of people. And if you multiply that out to the year, we're around 3,000 people dying per year from opioid-related. And that is not including other substances such as methamphetamine and cocaine. So this is a significant problem. Nobody doesn't recognize it as that, but I really wanted people to be present, or people to be present in the moment and understand what we had. Some other quick pieces of information that are important as well. During the pandemic, the number of deaths that occurred when nobody was present to potentially provide naloxone or other life-saving interventions was at 73, and we saw a greater number of fentanyl related deaths, and fentanyl now being the most significant substance that's involved in opioid toxicity. And as many of you know, many of you, certainly those who provide care, recognize that fentanyl has significant toxicity and a limited a very small amount can lead to significant impact. And so a small increase in the amount can lead to tragic and fatal outcome. And it's not very predictable at all in the supply, especially during the pandemic, where the supply was probably impacted by the border closures and other changes. We also are seeing more benzodiazepines. And those, again, people know, but just to reiterate for those who don't, benzodiazepines not only are impactful if there's an overdose because it's not responded to naloxone, but secondarily with withdrawal, you'll have withdrawal both from benzodiazepines and from the opioids, making withdrawal even more complicated and challenging. We also saw an increased number of deaths from people precariously housed or experiencing homelessness. And the reports drill more deeply into all of these topics, but wanted to give you some of the key points that were present. Next slide. And where did the deaths occur? What age? They're young people. They're really significantly, majority is between 25 and 44. You can see on the bar graph, on your left side of the screen is a 25 to 44. It by far is the majority or a greatest proportion of the number of deaths. And you can see that the rate has substantially increased during the pandemic period for those ages, and significantly maintained an increase within men. So younger men are most significantly impacted by this, and that is why we're seeing so many life years lost, and therefore life expectancy decreased for sure in BC. I don't know about Ontario at this current time, and we've also seen a number of the US states where life expectancy has gone down because of opioids. If you think about this, 3,000 deaths in about 100,000 deaths per year. This is a major problem of a preventable death. Next slide. It's across Ontario. It's across jurisdictions. It's across people. It's urban. It's rural. There is a higher rate in Northern Ontario, and there are a number of factors. Again, hearkening back to the discussions that I have that I'm involved with right now in Garden River and Sault Ste. Marie with many different elders from across Ontario, recognizing there is significance in a number of different jurisdictions across the province, but it really is not an individual. It's really everybody being impacted by this, and there's no other. It really is everybody. Next slide. And as I talked about, fentanyl is really the driver of this. We are now seeing mostly non-pharmaceutical drugs, and that has progressed and continued to move to being non-pharmaceutical and being fentanyl. And again, limited window or a narrow window of toxicity. And so with the unpredictable supply and the varying percentages of different substances that may be present, it's very difficult to predict, and greater risk for many that are using substances. And so we are seeing a significant increase in that. We are seeing decreased in deaths from those with pharmaceutical opioids. And you will recall now about 6 years ago, or maybe a little bit longer, where prescribing was felt to be the solution. While that may have made benefit with the pharmaceutical number of deaths, it clearly hasn't impacted the increase. I remember in 2020, the number of deaths that we were seeing was similar in 2019. And there was people saying, well, this is good. Well, there's no question it's good, but the number being similar is still over 1,000 people, over 1,500 people dying. So it still is not good. It's not good at all. It's terrible. And this year, what we're seeing compared to last year is approximately around a 15% increase year on year. So we still are seeing increased numbers. Hasn't been as significant for the first few months as it was last year, but this is early in the year and early information. So we're still learning and observing. The next slide. So this illustrates when we looked at the healthcare utilization, and there's a second study, our second report, again, two reports that are in there, one talking about what we observed and then talking secondarily a second report about the intersection with the medical history and the healthcare system. And this illustrates that during the pandemic, 1 in 4 people had interacted with the healthcare system in the week prior to their death. And so there are, and as you can see in the blue, outpatient visits, primary care emergency department visits, or other hospital admissions. And so don't have exactly where they all are in this slide, but you can read the report and see greater detail that allows potential opportunity for providing life-sustaining care at the moment, and then providing people the opportunity to enter on the journey of recovery. Next slide. At this point, I'm going to pass over to Matt, who's going to talk about some of the amazing things that occurred during the pandemic.
Great. Thank you, Dirk. Thanks, everybody. If you can just go back one for me just for a second. There we go. Perfect. Thank you. I don't want people to get distracted and dazzled with my slides before we're ready. So just a huge thank you. A couple of acknowledgements from me before we start. So just first picking up on where Dirk left off in his acknowledgements, it's been a great honor and privilege for me to get to know and work with Dirk. What might not come out in our discussion today, or it might, because sometimes it comes out at the most inconvenient time, is that Dirk and I share a sense of humor. Through some pretty challenging times with Helen, Angus, and David Williams, and a few others, I think a good laugh helped us get through some tough times. So at any rate, it's been a great privilege to work with Dirk. Just also in line of the acknowledgement, just a huge shout out to families and caregivers, healthcare workers. Just as Dirk has said with respect to the opioid discussion, I'm going to go through a few slides here with respect to COVID-19 and our response. Hard to celebrate anything when it relates to the pandemic and all that it's done, but there were some important lessons that we think might be applicable as we think about how we want to respond, in this case, to the situation with opioids. Just by way of introduction, with respect to my role with COVID-19, I had the tremendous privilege of being the co-chair with Helen Angus, Deputy Minister Helen Angus, and Chief Medical Officer David Williams for the first few waves, and now a real pleasure to continue that relationship with Deputy Minister Catherine Zahn and Chief Medical Officer of Health Kieran Moore. And anything I know about public health, which is about this much, I've learned from them. I'm going to talk a little bit about the pandemic and the response, and just some of our lessons that we've learned over the last while, and always trying to be conscious of the numbers underneath. And just to say that we're putting this in the context of opioids, but I think we stunned ourselves or surprised ourselves a little bit in what we could really do as a healthcare system as we move forward. So I'm going to take you through a couple of things that I think we're not going to cover every lesson, just a few that I think might be quite relevant to this conversation this morning around opioids. So if you can give me the click, that would be great. Okay, so this is just a visual of our testing network. The main point of talking about the testing network, at least in this context, was that before the pandemic, we didn't have one. And we were able to create over 200 specimen collection centers and network together over 40 labs to create a comprehensive testing network so we could offer specimen collection and testing literally all over the province and be able to deal with the time on that. If you can give me the next slide. So this slide, just to orient you to it for the moment, this is looking at our volume of what we were able to process on our lab network. And you can see in April of 2020, our volume and our capacity was at about 4,000 tests per day. And although you'll see a jiggling line along the way, we got ourselves up over 100,000. And most significantly for me, because these were the days where I had the great honor of having my name thrown about by the Premier almost daily in terms of how many tests we would be able to do per day. Our goal to get from April to October, so about 6 months, was to get from 4,000 to 45,000, and it was achieved, and so on. And so, here was a moment where we had to bring together great scale very quickly and very accurately. And a couple of the lessons here, this was not just the public labs, we had to get the private labs involved. So this was a public and private labs working together towards a common goal with common quality standards. We quickly put together an operating model and got everybody up and running. One more on the lab. Next slide, please. So just one more on the lab. This one to tell a slightly different story, but same idea. This is test turnaround time. And in this particular instance, the issue was we have absolutely fantastic public health teams all across the province. If they're not getting the information in a timely fashion, we're undermining their ability to provide great care. And this one stood out for me when I first saw the last slide that Dirk showed of this idea of many of the folks who ended up with an overdose had an encounter with our healthcare system relatively soon prior to that overdose, and thinking about, we figured out a way to get test results from all across the province into the hands of experts in public health management and do it quite reliably in the 24 and 48 hour range. Imagine if we were doing that and prioritize that for the folks who were encountering our system. Now, not every encounter would necessarily have triggered something, but it is possible. And look at the scale, right? We were doing this with 25,000, 30,000, 40,000 events in a day. And so clearly possible if we were to apply that to the context that we're talking about this morning. Okay, give me a next slide, please. Just to orient you to this slide, so this was looking at vaccine rates and looking at vaccine rates by age group and by neighborhood risk. And the main thing, just to juxtapose, as you can see on the chart, is how we were able to prioritize age and community. So again, the lesson here was the ability to identify where resources were needed and move those resources quickly and nimbly to get in there and start to support the communities that we need to support. A big shout out here to Alison Blair and Rhonda McMichael. If the folks on this call don't know those names, you should. They were absolutely fantastic in putting together the kind of infrastructure and response where we could move quickly to get resources into the communities where needed. I would also make the comment here, and it's going to be a comment sort of all the way through, and probably when we get to the Q&A, one of the most important things we also did was we didn't wait for perfection. So we weren't 100% sure how to, in this particular instance, how to get into particular communities. So we just went for it and tried, and we worked with the community, and sometimes it worked and sometimes it didn't. And those that didn't, we turned off, and those that did, we expanded. And that ability of not waiting for perfection, you'll hear that a couple of times. I know we talk about it, but this was a really, really big part of moving forward in our response. Next one, please. This slide, the visual, I wouldn't worry too much about what's on there, except to say this is just a subset of the information and the data sets that we were able to generate that even to today lead and result in a lot of our response. And some of the data that is on here now, this is 10 indicators. There's many, many more in behind this. Of these 10 indicators, some of these data sources existed before the pandemic and we repurposed them. Some of them existed and we didn't need to repurpose them. Some of them didn't exist at all. The key thing, though, was getting this stuff up and going very, very quickly and understanding what the different measures would be. And again, the idea here was move forward, don't worry about perfection. We knew that some of the data wouldn't be exactly perfect. For a lot of our planning, we don't need it to be exactly perfect. We need it to be directionally correct so that we could make the adjustments that we need to make. So this was great. And I would also say that speed of setup here, I've mentioned Helen Angus before. Helen, it was great to watch. Helen is for those of you who know Helen, Helen is a very soft-spoken leader. And when people would come and we would need a particular set of information and they would say that it would take more than a few months to get that up and going, she would very politely pat them on the head and send them back to the drawing board. When you're in a crisis moment, a few months is too long. We were able to bring this forward and move forward on how we can improve the system and improve the response that we've got as we go forward. So again, a few examples of what we were able to do to try to bring information forward. Next one. So this one is on the pivot to virtual care. And what, just again, to orient you to the slide a little bit, you can see on the scale is the number of primary care visits, and across the bottom, the time scale. And the purple line is the percentage of virtual visits. And what you see again here is in February, before the pandemic, virtual visits stayed as a very small part of our primary care response or our primary care function. It shoots up and then starts to correct. And a couple of things of why we wanted to bring this one forward as, again, something that we may want to consider as we go forward. First is note the concept of course correct. So as you can see over time, we're figuring out, we use a primary care system, is figuring out what's that right mix. Certainly virtual care has an important role to play going forward. Certainly where we were went a little too high. What's that right spot? But we didn't wait for perfection in order to do this. The second is this was a new model of care. This was a new way of providing services, at least at this kind of scale. So an ability to adjust, to make changes as quickly as possible to try to move forward is what we are showing here. And the adjustments to practice that can be made as we move forward. So those are just a handful of lessons that we've learned as we go forward. And now to see, is there a way in which we can support the great efforts that have been going on around trying to support people with substance abuse, substance use? Can we take some of these lessons and support that change? I'm going to hand it back to Dirk.
Thanks, Matt. If you can move on to the next slide, that would be great. So what have we done, and what do we still have lots more to do? And Zoe, welcome to the talk. Haven't seen you for a while or talked with you. Zoe Dodd, I think everybody should read in the chat Zoe's comments, very poignant and valuable points and perspectives that she has shared with us in the chat, but she has shared for many years, and a leader and somebody who has been really making all efforts in all different ways to try to raise this topic for all of us to understand and to make a difference with. So Zoe, thanks for sharing those comments. So from our perspective, now back in 2017, we recognized we couldn't even give the numbers. We weren't able to talk about the number of people that were dying. We knew there was significance, but we weren't able to share data in a timely and an effective way and understand the deaths to a greater extent. So we introduced an approach that allowed us to systematically learn about those that died and provide the ability to bring the understanding of those deaths into a process of aggregated analysis to be able to see and illustrate trends and patterns. So that was earlier a number of years ago, and now we're trying to integrate the learnings from that into our provincially into many different case management, case investigations, and have a timely system of IT case management, which we introduced over the past year during the pandemic. We're in the process right now of revising and looking at the approach to better and higher quality death investigations more generally, to develop a service delivery model that allows coroners approach to death investigation to be more consistent across the province and to be aligned with service level understanding and expectation. So that work is ongoing. We've just introduced a new unit that takes the goal is to take the death investigation information and to look for trend identification, not only in opioids but other circumstances, to be able to transfer that and to inform impactful recommendations. So we continue to take steps to improve our own organization to be able to best understand death and learning from those deaths and be able to share those in places where they can be most impactful. Next slide. So the next slide talks about what has happened, and there was a expert panel that the Center of Excellence with the Ontario Health, the Mental Health and Addiction Center of Excellence, which was pulled together in 2021, where there was an expert working group that looked at the substance use disorder. And they compiled a list of recommendations that had both immediate short-term, medium-term, and long-term actions for the sector. And many of those did align with some of the strategies that have been talked about during the COVID pandemic. For example, connecting service providers across the continuum, looking at a continuum of care throughout, targeted outreach for those populations at higher risk, virtual care to get more rapid access, and developing a focused strategy for data and analytics. And so while we know that, according to the expert panel indicates, well, we know what we need to do and what are outlined in their recommendations, know the tools and strategies to use, know that rapid progress is possible. It's really what can we do now to be able to bring together, learn from information from those who have shared with us before, as I talked about, and also move forward to mobilize a systematic and cross the continuum of care response to be able to reduce this terrible tragedy. So I'll pass back to Matt on the next slide.
Great, thanks, Dirk. And so a couple of thoughts as we bring this together and think about what can we do as a system, and how do we respond? And what we're considering here as we think about the recommendations that have come forward, and to Dirk's point, we know what needs to move forward. Can we do it faster? Can we do it at a pandemic speed? We certainly have seen that province-wide coordination is possible, and including, and very importantly, not just the health system, looking at municipal systems, the private sector as well. We were able to do that in COVID. Let's do that here in this response. I've already mentioned the speed to implement and getting information out and available, and really trying to make sure that we're comfortable with the idea that we're going to have to iterate on that. And one of our challenges, and one of the things that certainly was a challenge through COVID, was the idea that we would wait until all of the data was perfect and everybody was in alignment. And the concept is, let's try to move and put action ahead. Same with the rapid research synthesis. And this is one of the things, and a huge compliment to David Williams, to Kieran Moore, to our public health folks. You know, in COVID, the information and the science was changing. There were different things that were coming forward, and there wasn't always agreement, certainly not on Twitter and on other places. But we still moved forward. We took the best information we had and did what we could with those findings and moved forward on that basis. We did also schedule updates, and it was a bit challenging at times when the response would pivot, would move to a different path. I think about, and just as an example, when we would change testing criteria. Changing testing criteria was a very, very difficult process. It was confusing for the public. There was some backlash, but you have to move with what the research is telling you, what your best evidence is, and not wait until everybody is in total agreement, which tends to be a problem for us in other parts of our system. Moving to real-time intervention capability, have already commented on where we might be able to go with that, and take some of the lessons, when we think about from a COVID response, being able to put in place within a few months, a system that was able to provide information at both an individual and a community-based level. Typically, that data was available within about 48 hours. Even at worst, it would have been a week. And so those are the kinds of things that we're going to need to make sure we support if we really want to make the change here and support the wonderful recommendations that have come forward from the experts. And then finally, there has to be an expansion of services. And so it's not just an idea of reorganizing a few things. And to Dirk's comment, this has been on the table for a while. I know many have been pushing on this. We have to do it. That's what we did within the COVID response. The one nuance that I would add here that maybe has been talked about, but certainly was a key part of the response from a COVID perspective, was the design provincially but implement locally. And again, maybe I'll use the testing example, although we could use IMS structures. We could look at what we did with things called MEST teams within long-term care. But we always set, here's the overall direction, here's the numbers or the outcome that we were looking for, but then over to local teams to figure out what's the best way to do that and achieve that within their environment. So again, taking some of those things, and seeing if in combination, we can start to remove some of the barriers that have been in that way from making progress on this important issue. Again, so we're going to end there. We're going to go to the questions. I'll reiterate from Dirk's perspective. First is, we talked about numbers and we talked about ideas and successes. And at no point would we ever want to forget the human cost that is underneath all of this. It's very near and dear to me as a person, and something that we have to be aware of. Second is, and I said off the top of my talk, it always feels weird to be talking about positive things coming out of the pandemic. It's just a difficult concept for me personally, and a difficult concept for many. So we're not really saying positive things, but lessons, things that we think have changed the game and how we approach things as a healthcare system. And can we now take those lessons and apply them more broadly, particularly to the crisis point that we have with opioids? And with that, I'll pause there and we'll go to questions, which apparently we will ask. I'm going to ask Dirk the first one that's on the list. For context, how do deaths from opioids compare to deaths from smoking, motor vehicle accidents, etc.?
So thanks, Matt. Excuse me. So if we look at the number of deaths in Ontario annually from car crashes, would be approximately 600. Smoking is with all of the complications related to cancer, emphysema, high cardiac, is estimated to be around 16,000. And then if we think of the number of homicides in Ontario and think of the resources and the commitment and the public awareness, it's approximately 300 deaths in Ontario. So recognizing the significance as numbers go, so 3,000 compared to 300, but also the significant importance of the number of life years lost for these for people who are young, people who are dying from a preventable disease or illness, not disease, preventable cause. And so important that we reflect on this from more than a single perspective. 300 was from homicide.
Thanks, Dirk. Next one we have is from Rebecca. You mentioned we struggle to respond and mobilize. How is Ontario Health supporting that and breaking silos? So probably I should take that one, Dirk, I would say. I think what we saw in the pandemic was, and maybe some of you saw as well, things like our IMS structures and our work within the regional tables, where we bring together folks from different sectors, I guess we can call it that, to troubleshoot how we move forward. One of the key things that we want to do, of course, is move forward as strongly as possible on the Ontario Health Team agenda. And the Ontario Health Team agenda, which looks at how do we get a bundle of resources and into a community so the community can respond in ways to keep people healthy, look at the preventative care aspect of it, as compared to funding individual agencies for tasks or things that they need to do. So it's a brilliant and important concept, and that will be the structural way that we would do it. But internally, or in the meantime, is making sure that when we have our planning tables and when we're looking at resources, how we can look at it across silos and across systems. Just one last example on that for me personally, I have a health system advisory group that represent folks from all sectors. And for me as well, I've been very fortunate in that we have people attending who aren't really from under the oversight of Ontario Health. So public health, people from public health assist with the planning, primary care. And we do have to start to think of ourselves in that fashion, right? And one of the comments that I made earlier in this is that if we stand and we say, well, this group is funded this way, this group is funded this way, and this group is funded this way, and therefore the groups aren't going to do planning together, I think we're in real challenge, and we're going to have to move past that. The next question, there's a question here again from Rebecca from Viva Google. I do not know the answer to this. Do you know that? Dirk, would you be able to answer this? Okay, I'll read it out. Viva Google and the Pan-Canadian data strategy talks about poor data sharing. How are you addressing that? How are you sharing your data and ensuring its access?
So not speaking specifically about the Pan-Canadian data strategy, but the conversation that I'm aware of those discussions. From our perspective, what we do is our data is shared on a regular basis. We share monthly with the substance-related harm with the public health units across Ontario. We also share regularly with other system partners, other people that are involved, and we have we do the 2 reports, which will be included in here. So our data is open and available and accessible in response, and also we share proactively on, and we also have it's present on the Public Health Ontario website. There's a tracker, opioid-related tracker, ODPRN, separate from us, does a number of publications and releases those and publicly puts them forward.
Great, thanks. Maybe I'll just add that likewise, we absolutely have to, as we did with COVID, getting the data out in the public domain and making sure that everybody can see it, have access to it, was a critical part of the strategy and needs to be here or any other main large change initiative that we want to move forward on. Next one is for me from Zoe. How would a healthcare system be responsive to people who use drugs, who use recreationally, since a large number of people who died, not labeled with a substance use issue, died? So if I understand the question correctly, in the case of COVID, where we were able to take a positive test and identify through that positive test and then do a trigger, in the instances that you're describing, there wouldn't be that front end element to it. So I guess I would say a couple things to that. First is that where there is, and where we have that opportunity to intervene, we should, and we should be making sure that we've got the systems that are able to do that. I think you speak more broadly, though, to a public health strategy and a prevention strategy, and looking at how do we communicate better, and how do we drive some of those changes, and try to, through education and through prevention techniques for those who are using recreationally, and see if that would make a difference in supporting them. Dirk, did you want to add into that?
No, I think, no, not specifically.
Okay. Got one here from Renato DeSenza. Hi, Dirk and Matt. Thanks for all the work your teams are doing. The opioid crisis has some genesis in the legitimate healthcare system. Are we looking at the pain management system, clinics, quality standards, et cetera? The approach seems a bit scattered between clinics, mental health, and primary care. Reforms to prescription guidelines may not be enough. Do you want to take a first shot at that, Dirk, and then I can add?
Sure. I think, Renato, you've illustrated and amplified some of the conversation that's occurred in the chat. And the focus on prescribing it isn't the solution. And there are many other things that need to be considered. As when there was prescribing, there was the potential impact on pain management. And so that, as you say, was impacted in that way. There are people that have specific expertise and that are approaching this, and I don't have all of the details into it, back into the treatment area, which is outside of my specific knowledge, but I know that this is something that's recognized and recognizing again that the prescription guidelines was not the solution to this very more complex and challenging issue. And again, I encourage everybody to read the chat. We won't have the opportunity to answer all of the comments in there, but they're very important and impactful and insightful and valuable and necessary things to read.
So thank you very much, everybody. Thank you for the comments as well in the chat. We do have a number of folks on from Ontario Health, from the Mental Health and Addiction Center of Excellence. So all very helpful on the feedback and on the questions. So thank you. And thank you for taking the time this morning.
Thank you very much.